Good afternoon, everyone. I hope you can hear me. I see most of our colleagues from the hospitals have not joined, but for the sake of time, we are just going to begin. So, as usual, my name is Dr. Kevin Raphael, the coordinator for Echo Sessions. I welcome you today. This is our 53rd Echo Sessions, and our main objective for today is going to be anesthesia, and our lead partner are going to be SATA. So as usual, I would like to share with you the etiquette. Always make sure that if you are not speaking, make sure your microphone is muted so as to avoid any audio interference. If you want to speak, make sure you raise your hand and I will give you a chance to speak. The mute function is at the left bottom corner of the screen, so make sure to use that. And make sure you do not have a backlit so that we can see you clearly. And for those spoke hospitals, we want to make sure that our videos are turned on so that we can have an interactive session. So for example, Musoma and Bukoba, it's going to be better if you're going to turn on your video so that we can have an interactive session. And if you have any issues, make sure to send them through the chat. I hope all of you can hear me clearly. And I'm now going to share with you the agenda for our session today. So as I said earlier, today our main objective is anesthesia, and our lead partner is SATA, Society of Anesthesiologists of Tanzania. Our specific objective for today is going to be on the management of difficult airways. As you can remember, we had this session last year, on October last year, we discussed this part, but due to many recommendations from our fellows, we have seen it necessary so that we can repeat this session. So we're going to be discussing on the management of difficult airways. As usual, we begin with the introduction remarks, and then we are going to have a patient case presentation. This is going to be on the case of difficult intubation, and it's going to be presented by Johaves Josiah, a nurse anesthetist from Bukoba Regional Referral Hospital. We chose Bukoba Regional Referral Hospital today. Some of you who have gone through the schedule will notice that today it was Tarime's turn for presentation, but unfortunately the anesthesia provider in the site were quite busy and could not manage to prepare the case in time. So Johaves instead from Bukoba is going to lead us through the patient case presentation. After that, we are going to have a question regarding the presentation, and then we are going to welcome Dr. Peter Saria, an anesthesiologist from CCBRT Hospital, and he's going to take us through the didactic presentation on management of difficult airways. Dr. Saria is not new to our session. I think he's very common and we all know him. I'll give him a chance to introduce himself. Afterwards, we are going to have a session where we are going to have a general discussion, comments and recommendation, which is going to involve all of us participants. And then at the end, we are going to have concluding remarks and announcements. After saying that, I would like to welcome you all now to our session. I would like to begin by welcoming Dr. Saria just to introduce himself briefly, and then we are going to go on. Dr. Saria, please welcome for introductions.
Thank you very much, Dr. Kelvin. My name is Dr. Peter Saria, anesthesiologist who I'm working at the CCBRT Hospital in Dar es Salaam. And as Kevin said, this is I've been in this session for quite some time, so I'm not new here. And since the participant has requested for this session, I'm sure there will be a very much active participation. In my presentation will just be 5 minutes. I expect a lot from them, because from them then we can have a good discussion. Thank you very much.
Okay, thank you, Dr. Saria. So I hope we are all prepared. I think we have prepared all the questions regarding management of airways. Even if it's not for the anesthesia providers, even the medical doctors who are here and you would like some clarification, you can please contribute so that we can have a productive discussion. Also, we have Huntington from Assist International has joined the session as well. So we are going to begin. I don't know, Johafes, if you are ready to take us through the patient case. Okay, Johafes, should I share the screen for you?
Yes, Dr. Kevin, my camera is not good, but I think you can assist me on sharing.
Okay, no problem.
From where? Yeah.
Can you see the screen, Johafes?
Yes.
Okay, please continue.
Thank you. Hi, everyone. My name is Joafes Josia from Bukoba Regional Referral Hospital. This is a case presentation on management of difficulty intubation. This was happened at Santa Joseph Kagondo Hospital. Next slide, please. Yeah, another slide, please.
I have shared, I have put to the next slide. Can you see?
No. Okay.
Johafes, can you see now the presentation?
No, I don't see the next slide.
Okay. Can other participants see the slide?
No, we cannot see it.
Okay. Okay. Give me 1 minute. I'm reopening and resharing the slide for you. Johafes, can you see the presentation?
No. Yeah, I see the first slide now.
Okay, what about now? Can you see the second slide? I've gone to the second slide.
Yes.
You can see it now.
This is message. Okay. Okay, I think I can continue.
Yes, please continue, Johafes.
This is which 45 years old, Yeah. And I'm sorry, I'm with my
Joafes, we cannot hear you. Are you still there with us? Joafes, are you still with us, Joafes? I think do other participants having a difficult time to hear Joafes as well?
Yes, Kevin. Yes, we cannot hear you.
Okay. I think Joafes is having some network problems. Joafes, are you still there? Joafes, we could not hear you, but we can see you. I wonder if everything is okay with your audio. Joafes, can you hear me? Can you confirm if you can hear me? Okay. Try to speak. You're unmuted, but it seems like we cannot hear you. Joafes, is everything okay? Okay. Okay.
Hello, Kevin.
Yes.
I think if there's a problem in network, maybe I can just take on and present in this case, and then we can have a discussion based on the case.
Okay,
Of
no
course,
problem.
I will not be able to pick up each and everything, but for the sake of the time, maybe we can.
Yeah, I agree with you,
We
Doctor.
can proceed.
Yeah, let me present the case on behalf of Joafes. I will just present the case on behalf of Joafes very quickly because I
Okay.
think he's having some problems. So this was a. Can everyone hear me clearly?
Yes, we can hear you.
Okay, so this was a
Yes,
case
I can hear you.
of difficult intubation, which happened at St. Joseph Kagondo on March 2019. So the patient was Mrs. X, aged 55 years old, who was admitted on the 9th of March 2019 and complaining of neck swelling for 3 years. She started feeling difficulties in swallowing a year prior to coming to the hospital. So on local examination, she had a swelling on the anterior side of the neck, no any visible palpation, it's not tender, smooth, pickable, moves up and down on swallowing. Her vital signs, blood pressure was 140/90 millimeter of mercury, pulse rate was 88 beats per minute, and respiratory rate was at 15 cycles per minute. Investigations that were done were thyroid function tests, which revealed normal levels for T3 and T4, and the diagnosis established was a simple goiter. She was admitted to undergo a surgical procedure of thyroidectomy. A pre-anesthetic visit was done, and the following were the findings. The planned surgical procedure was thyroidectomy. It was a first exposure to major surgery and anesthesia for this patient. On examination again, blood pressure 140/90 millimeter of mercury, pulse rate at 88 beats per minute, and the respiratory rate at 15 cycles per minute. Dental status, teeth were intact and complete. Head and neck was rotating well and in good range of motion. Assessment of the airway, thyromental distance was 7 centimeter. Malampart was class 3. Mouth opening was able to admit 3 fingers. Because of Malampart class 3, they anticipated difficulty intubation. So difficult intubation was diagnosed. On 10th of March 2019, in the morning hours, the patient was brought in theater for surgery. Before induction, vital signs were monitored and were found to be normal. Equipment for intubation were prepared as follows. So the first one is endotracheal tube number 6.0, 6.5, and number 7. Laryngoscope with blades, number 3 and number 4. LAM, I think, I'm not sure of the long form of LAM. Dr. Saria will correct me. And the face
It's
mask.
the laryngeal airway mask.
Okay, laryngeal airway mask and face mask. Bougies, introducer and suction machine. Also, drugs of induction were prepared. Atropine 0.5 milligram, thiopenton 250 milligram, and suxamethonium 100 milligram was prepared. Before induction, pre-oxygenation was done up to 100% oxygen saturation. Both first and second attempt of induction failed, and the patient was starting to desaturate, and the oxygen saturation dropped to 80%. Face mask ventilation was done, and oxygen saturation raised up to 100% again. Introducer was used with endotracheal tube number 6.5 to intubate the patient, and that was successfully done. Operation went well, and the patient was discharged from theater to recovery and then to the ward. So the lesson they learned from this case, I would like to ask the one who have, please make sure you have muted your audio. Okay. Okay, the lesson learned was the use of introducer can help to save the life in the situation of difficult intubation. So this is the end of the presentation. This was prepared by Philbert from Kagondo Hospital. Thank you all for listening to the case. So this was the patient case. I hope we have all heard it. Sijui kama tuna maswali concerning this case. Any point that we can discuss. If no questions for now, you can think of a question and send it through the chat. So if a question comes up, you can send your question through the chat, and then we will discuss it later. Now, Dr. Saria, I would like to welcome you. Since we've gone through the case, the patient case, please take us through the didactic presentation.
Okay, thank you very much, Kevin. And so allow me to share the presentation, please. Okay. Now I'm having the problem in sharing the slide. I don't know.
Okay, maybe I can. I think I can share for you your presentation.
Okay, you can share it.
Okay.
still having the problem. You are sharing the slide. Maybe I can have a few comments on the presentation, or maybe we can spare it until we finish with the didactic presentation.
You can, I think, Doctor, you can just go ahead with your comments. We will
Yeah,
even
because all right. All right. I'm expecting a lot of questions from the anesthetists from different hospitals based on this case. But first of all, I would like to congratulate the St. Kagondo Hospital because it is clear that this was anticipated difficulty airway. Once we have a patient who is having swelling on the anterior of the neck, you have to anticipate difficulty airway, and especially difficulty intubation. So what you can do when you have this kind of patient is, the first thing is preparation. If you don't prepare yourself, you may end up in a critical situation whereby you will need an assistant or you need a certain equipment, but it will not be there because you haven't prepared. So this was anticipated difficulty airway. And what they did, as you can see, they prepare each and everything. They prepare the endotracheal tubes with different size, because once you have the swelling of the anterior of the neck, even the aperture, I mean the opening in the vocal cords will not be the same. So you may end up with difficulty in putting the tube. So as a result, I mean, as you can see, they prepare tube number 6, tube number 6.5 and 7.5, hoping that when the 6.5 is bigger, they can use 6.0. Or when they try with 7.0 and become bigger, they will go back to 6.5. That's the essence of having different size of the tubes. And again, you can see they use the introducer. Of course, for the introducer, the real name is, or the proper name is bougie. So this is equipped. I mean, is a wire or a rod whereby you can blindly put through the larynx, hoping that it will find the vocal cord, and then you put the tube through the bougie. So I would like to congratulate them. Now, quickly, let us have in the didactic presentation, and then from that we can have a discussion and questions. So this was a presentation which was done last year, and this is just a repetition. So we'll go quickly. Please give me slide number 2. And this will be our outline. We'll have just an introduction. We'll see the predictors of difficult airway. We'll look on the preoperative assessment, and then management of difficult airway. And at the end of the day, we'll have a summary of the presentation. Next, please. So the definition of difficult airway, or of course difficult airway, is when the anesthetist or anesthesiologist who is well trained or experienced failed to intubate or failed to ventilate the patient with the conventional, with the laryngoscopy or with the aid of face mask. So when you fail to ventilate the patient and you fail to intubate the patient, we say now you are having a difficulty airway. And this must be done by an experienced anesthetist or anesthesiologist who is around. You cannot say difficult airway when it's just a junior or naive practitioner who has just tried to intubate and failed. You say this is difficult airway. It has to be done, tried at least 3 times, and one of those 3 times must be tried by experienced anesthetist or anesthesiologist. So when you fail, then you say this is difficult airway. Next, please. So this difficult airway or difficult intubation, it represents a complex of interaction between many factors, but main are the patient factors, the clinical settings, and the skills of the practitioner. So the patient factors include things like we have seen from the case presentation, the swelling on the anterior of the neck, process. You know what to do. You know this is difficult airway, but you don't have different size of the laryngoscopes, or you don't have bougie, you don't have LMA, the laryngeal mask airway to ventilate the patient. So in that setup, then you will have a limitation in terms of clinical background. And the skills is when now the patient has no any problem, everything is available, but the practitioner is lacking the skills when it comes to airway management, especially intubation or ventilation. And when both tracheal intubation and supraglottic airway devices insertion fail, then you may start thinking of waking up the patient, because now you have failed to intubate, you have failed to ventilate with the supraglottic devices like LMA. What is the option now? The option is try to wake up the patient. Next, please. Now, the incidence or the prevalence of difficult intubation in non-pregnant women, or yes, non-pregnant women is very low. But in pregnant women, as you can see, the incidence is reported at around 0.45 up to 4 to 5.7% of the patients. So it is quite common in pregnant women as compared to non-pregnant women. And why is it common in pregnant women? Is it because of the physiological and the anatomical changes which occur during pregnancy? The issue of airway edema, issue of hormonal changes, all of this brings the airway edema, desaturation. This woman desaturate early, so all of this contribute into the problem. Next, please. And so failed intubation is much less common than difficult intubation. We have, these are two different things. When you say failed intubation, that means you have tried 3 times to intubate the patient and you fail. But when you say difficult intubation, is that you experience difficulties during intubation. These are two quite different things. But as you can see, failed intubation is less common as compared to difficult intubation. Next, please. Okay, so this is just to highlight you for the report which was released in UK. This is called the National Audit Project 4. And they were trying to assess why mortality and morbidity in patients with failed due to difficult airway. And they found that all this problem, all this mortality were related to the issues on judgment, when the clinician is on the is supposed to waking up the patient but delayed waking up the patient, end up into complications, or there were things like miscommunication between the anesthesia providers or between the team. So there must be a good communication between the team, or fail to have a good planning. You have seen this is anticipated difficult airway, but you don't call the ENT surgeons, you don't prepare the cricothyrotomy set, you don't prepare the tracheostomy set, you don't have prepare the fiber optic if you have the luxury of having fiber optic, you don't prepare all the drugs and equipment in advance, may end up into problem. And training, so also the lack of training also, especially in low resource countries, may also lead into poor outcomes. So things like judgment, communication, planning, equipment, and training, all of these are things which are within our capacity. So we can also try to avoid all of this, which can lead into complication. Next, please. Now, that was just an introduction of difficult airway. Now, the second part of this presentation was to look on the predictors of difficult airway. From the cases, from the case scenario, we've seen that this patient was Malampart 3. So when they said going to say this patient was Malampart 3, it is this one. This is the Malampart 3 patient. As you can see, you can only visualize. Yes, thank you very much. You can only visualize the tongue, the soft palate, and hardly you can see the part of the uvula. as compared to Malam Part 1, whereby you can see the tongue, the soft and hard palate, you can see the whole of the uvula, you can see the pharyngeal porches and the recess. So when you have this Malam Part classification, is very important when it comes to airway management, because patient with Malam Part 3 or 4, you anticipate difficult airway or especially difficulty intubation as compared to patients who are Malam Part 1 and 2. So when you are examining the patient, when you are doing your airway assessment, try to look for the predictors of difficult airway, and start with the difficult ventilation, because the essence of, the primary goal is to ventilate the patient with oxygen. So if the patient has restricted mouth opening due to either radiation or other connective tissue diseases, or if the patient is having a foreign body, the obstruction due to either foreign body or a mass, patient who are obese or patient with obstructed sleep apnea, all of them may have difficulty in ventilating when it comes to ventilation. The mask, if you don't correct, if you don't assess the patient carefully, sometimes it may become very difficult to seal the mask. And when you cannot seal the mask around the mouth, there will be an air leakage of oxygen. Then ventilation will not be possible. And other factors are age, more than 55 years. This was just in epidemiological reason. We don't know why age above 55, but as you can see, age above 55 are the one with comorbidities, are the one who are having no teeth, are the one with a lot of condition which may put them in the risk of difficulty ventilation. Next, please. So another predictors of difficult airway are those predictors of difficult intubation. So when the patient is having a short neck, like the one you can see in the picture, or obesity, or a pregnant woman, as we have seen, the reason why the pregnant woman have difficult intubation, when there's restricted of neck mobility, patient who are having diabetic mellitus, patient with the rheumatoid arthritis, all of them have difficulty in neck movement. So all of them also may end up into difficult intubation. Of course, as I've seen, Malam Part score grade 3 and 4, restricted mouth opening when you are doing your thermomental or whatever. Thermomental or hymental distance, when it's less than expected value, you may end up with difficult intubation. Next, please. So those were the predictors of difficulty ventilation and difficulty intubation. Now, having knowing the predictors now, what are the preoperative assessment? In airway is quite easy. Just do your history and physical examination. History, try to ask the patient if has history of surgery. And if yes, was she or he given local anesthesia or general anesthesia? When the patient say general anesthesia, try to ask, were there any difficult problem in your airway? When you ask the patient and say no, at least you know, okay, there was no, I'm not anticipating difficult airway. Sometimes also you have to review into the files. It is recommended that when you are facing any difficulty in difficult airway, you have to write it in the file of the patient, so that the next practitioner, when it comes and review the file, may get information that, oh, this patient was difficult when the previous surgery was done, so I have to take care of those issues. So history and physical examination is very important. And then you have to assess the airway, but most of the time try to look externally. If there's a mass, any abnormalities, you can notice. Then try to evaluate. When you evaluate airway by the rule of 332, 332, as you can see on the diagram on the right side, the first one is try to measure the inter-incisor distance. This is the ability of the patient to open the jaw. So if the patient can accommodate 3 fingers, at least you are safe. The next, that is A, and on the B, that is hyomental distance, the distance between the hyoid bone and the mentum. At least it should be 3 fingers. And the last one in C is thyromental or thyromental distance. This is the distance between the thyroid to the floor of the mouth. So these are just parameters to at least to give you a clue that, oh, I will anticipate or I will not anticipate difficult airway, because if the patient can only accommodate 2 fingers, even so, that means it is difficult to open the mouth full, then it will give you a difficulty in putting your laryngoscopy and end up in difficulty intubation. The same apply to B and C, the hyomental and thyromental, the explanation is the same. And also the issue of malampatu we've already discussed, the neck mobility and obesity. Next, please. Now, after assessing, then you have to prepare yourself, or you have to manage it when it comes to airway, difficult airway. So the management now will depend on 2 factors or 2 issues. If this is unanticipated or anticipated. And we have the chart, the flow will be in the next slide, we'll see the algorithm. But the importance is just to prepare the drugs, the equipment, have a personal assistance in hand, and also the main goal, especially in pregnant women or in emergency surgeries, please prevent aspiration. Next, please, Kevin. Now, when it comes to drugs, there are a lot of drugs, both for induction, muscle relaxant, and whatever. But I'm talking of anticipated difficult airway, ambazo tunatarajia kwa Kiswahili kwamba natarajia kesho nitakutana na difficult airway. So when you have anticipated difficult airway, you need to be very careful in your choice of drugs, because once you anticipated difficult airway, the primary goal is to make sure that you will not depress the respiratory system of this patient, because once you depress the respiratory system and you fail to intubate, this patient will desaturate. So when you anticipate, try to use induction drugs which will preserve the respiratory system of the patient. And some of these drugs are ketamine, and if you use a low dose of midazolam also, it can be good. But if you anticipated in children, you can try to avoid all intravenous drugs. Try to induce the patient, the child, with the inhalation, because inhalation at the correct dose or at a correct mark, they preserve the respiratory system. So that when you try your laryngoscopy and you fail to intubate, at least this patient will be breathing by his or her own, and then the issue of desaturation will not be there. But assuming you are having this difficult intubation, you have given the patient the propofol or the thiopental or etomidate, you have paralyzed this patient with the suxamethonium, pancronium, or trachurium, and unfortunately, you failed to intubate. You try to ventilate, again, the patient is having a mass. After giving muscle relaxant, that mass end up completely in obstructing the airway. So you fail to intubate, fail to ventilate, the patient is not breathing because we paralyzed the patient. So you end up with a critical instance. The patient may end up into cardiac arrest because of hypoxia. So always the take-home message is that try to avoid those drugs which may depress the respiratory system when it comes to anticipated difficult airway. So the best option for anticipated airway is try to involve the ENT surgeon. You can plan to do tracheostomy as an elective under local anesthesia. You go there in theater, under local anesthesia, you perform your tracheostomy, you put the tracheostomy tube, and then the next day or the following day, you go for the surgery. Because you have the tracheostomy in situ, you can just put the tube there, connect the vent and continue with your induction as usual. Or you may prepare for fiber optic or video laryngoscopy, and make sure that the surgeon or the ENT surgeon is present in the theater, so that in case of emergency they can do emergency tracheostomy. That is for anticipated difficult airway. Of course, you have to have the emergency drugs like atropine, adrenaline, or vasopressor, because the hemodynamic might change, so you need those drugs to give the patient. Next, please. Of course, for emergency equipment, so you must have the suction machine, because the patient might aspirate, regurgitate. You have to enter the catheter. You have to laryngoscope with different blades and different size. So you must have a straight laryngoscope. You must have curved laryngoscope with different blade size. You have to have your endotracheal tube of different size, stillets, the bougie, as you can see, St. Kagondo. They failed to intubate with the conventional laryngoscope, but when they use bougie, they succeed to intubate. Of course, oropharyngeal airway, laryngomask airway, and others. All this airway equipment will help you in case of emergency. Next, please. And don't forget to have an assistant, and try to have assistants who has knowledge and skills in airway management. The surgeons, the nurses, the scrubbing nurses, anyone with skills in airway management is better than others, but everyone has a role to play. So make sure that when it comes to critical incidents, everyone has to play part in make sure that this patient is not going into hypoxia and cardiac arrest. Next, please. Then the approach to difficulty, I think I've already spoken about that, but the main issue is make sure that you pre-oxygenate the patient for at least 3 to 5 minutes, so that even if you get the difficulty, the patient will have the reserve of oxygen into the airway. And also position of the patient. Sometimes you may fail to intubate it just because the position is not good. So if you keep on repeating the laryngoscopy without thinking of the position of the patient, you may not achieve anything. So once you fail to intubate, try to check if the position is adequate. The neck position, if you can put pillow below the shoulders, or if you can put pillow below the head. So do all the maneuvers in terms of position to enhance or to increase the chance of visualizing the vocal cord. And for elective cases, for the patient who has already fasted, before giving muscle relaxant, try to check if you can bag mask. You can ventilate the patient with mask. With a bag, so that even if you fail, at least you can ventilate the patient. And as I said, limit the number of attempts to allow for more senior or experience, because if the same practitioner, the first attempter is trying to do the same, you traumatize the airway, you increasing the bleeding in the airway, swelling in the airway. So, and then even if when the senior or experienced come, the anatomy is already distorted and then become very difficult. Increase the residual capacity. Follow the algorithm. Next, please. And the most important things for during airway management, as I said, especially for emergency surgery or to pregnant women, is to make sure that you prevent aspiration. Remember, all pregnant women are termed as full stomach. So the only way we can do, is by rapid sequence induction with critical pressure. And remember, for this woman, there is no, for pregnant woman or for emergency surgeries, there is no role of bag ventilation, because you will increase the intragastric pressure, and the patient may vomit and end up into aspiration. For elective, we have to fast the patient for at least 6 hours before surgery, and also you can use pharmacological prophylaxis like H2 blockers, like omeprazole, ranitidine. You can give even the non-particulate antacid like sodium citrate, so that even if the patient aspirate, the patient will not aspirate acidic content rather than alkali gastric content, which will have less effect in the lungs as compared to acidic. Next, please. And this is just a logarithm for an anticipated difficult airway during cesarean delivery. As you can see, this was unanticipated. We didn't know that we can end up with this situation. But when you fail to intubate for cesarean delivery, what is advised is just maintain the cricoid pressure, then call for help, apply supplemental oxygen by nasal cannula, and then because we cannot ventilate, so you have to position the patient. So if you succeed, then you proceed with surgery as normal. But when you try your second attempt and you fail to intubate, then you have to attempt mask ventilation, because now you have failed to intubate. The primary goal now is to ventilate the patient with a mask. So if you succeed to ventilate the patient with the mask, then you have to ask a question about the maternal status. If the maternal status is unstable, you cannot say we cannot proceed with surgery. So you have to proceed with surgery because the maternal status is unstable. But when you have failed to intubate, you have attempted mask ventilation and you fail, now you have to try using the supraglottic airway devices like laryngeal mask airway. And if you succeed, then you assess again the patient. Is the maternal status stable or unstable? If unstable, you proceed with the surgery. If it is stable, you have to include now this is a multidisciplinary approach. So you have to assess the fetal status. You have to assess the confidence in maternal airway management. So if you can proceed with just an LMA, you can just proceed with surgery. But if the maternal status is stable, the fetal status is stable, and then you can just wake up the patient and plan for other alternatives like fiber optic intubation, tracheostomy, all of these. So this is just a logarithm for unanticipated difficulty in cesarean section. Next, please. And this is difficult airway. Even if it's a cesarean section, you have to plan either for regional anesthesia, spinal anesthesia, epidural anesthesia, or combine both spinal and epidural anesthesia. But sometimes, if you succeed, then you proceed with surgery. But you may fail to put your spinal needle, you may fail to put your epidural catheter, you may fail, you are combining both spinal and epidural. So when you fail, continue to supplement the patient with oxygen, and then proceed with surgery. So if the option is to proceed, to waken up the patient, then you awake the patient. And then if the option of awake the patient, you have you can, which are always available in most of the hospitals. And remember, the standard one in most of the hospitals of the institution where you use society algorithms. So try to go into the internet. These are free available material. The difficult airway society, you can get all the algorithm in different scenarios, all kind of cases. Next, please. Oh, now, thank you. This is now time for discussion. Thank you very much.
Thank you so much, Dr. Saria, for the very informative didactic presentation. I hope all of us have heard the presentation, and perhaps we have questions as we now head to the discussion part of our session. So I would like to welcome questions regarding the previous presentation. For any of the surgical teams who have joined the session, if you have any question, this is the time to ask so that we can discuss this. Dr. Saria, as we are waiting for questions from other spokes, as I was listening to you, I was thinking of a case scenario which might be challenging, and I thought maybe it's going to be a good point for discussion. So, for example, for instance, when you receive a patient who is seizing, a patient who has convulsion or seizures, perhaps has head injury, who's in need of emergency surgery, and you cannot say maybe he has a spasm of the jaw muscles, and somehow you cannot intubate through the mouth. I would just like to know the approach. I don't know if you mentioned it in your presentation in a case like this.
Okay, so when you have the patient who is convulsing, so the first thing is to arrest the convulsion. And we all know the drugs which can be used. There are different approaches. We have the benzodiazepines, like diazepam or midazolam. And when you fail to control the convulsion with, let's say, benzodiazepine, we know we have the option of using the barbiturates like phenobarbital, or sometimes we use also phenytoin. So when you get the patient who is having convulsion, for sure this patient continually having this seizure may lead into obstruction of the airway. So the primary phase is not to consider intubating this patient. The primary goal is to control the seizure and open the airway with just head tilt, jaw thrust, and chin lift. And if possible, put the oropharyngeal airway or a spatula because the patient may bite the tongue. So try to do the basics airway maneuvers to open the airway, jaw thrust, head tilt, jaw thrust, chin lift, and put in the oropharyngeal airway. You'll be open the airway. And then if this patient continue having the convulsion, now the diagnosis will be status epilepticus because you failed to control the convulsion, the conventional treatment or the drugs. So this patient will be needed to be intubated. And the drugs now, you can use any, but you can either use benzodiazepine, high dose of benzodiazepine. You can use thiopentol because thiopentol also can control the seizure, or because it's also a barbiturate. Or you can use whatever the drugs, but keep in mind that because this patient is an emergency, this patient will be having full stomach, so you have to perform a rapid sequence induction to avoid the risk of aspiration. And when it comes to head injury now, when you get this kind of cases with the head injury, the first thing to ask yourself is there any bleeding through the mouth, nose, or ears? And when the patient is having bleeding through the ears and nose, we know that this is a middle cranial, the cranial bones injuries in the middle fossa. So there is a risk of if you want to intubate the patient, you will avoid the nasopharyngeal intubation because you may either go into the CSF and introducing infection to the central nervous system. The patient may get the meningitis. So, but if the patient is not having bleeding through nose or ears, the chance of having injury to the base of the skull is minimal. So you can, and if the patient is having bleeding through the mouth with secretions, you can try intubating through the nose. But even if you intubate through the nose, you need also to visualize the mouth, because you have to have the forceps, the McGill forceps, to pick up the tube from the mouth to introduce and then direct it to the vocal cord. So what you can advise is make sure that you have the working suction machine, so that you can suck all the secretion through the mouth, so that you can visualize the vocal cords. And the choice of drugs now, you have to make sure that you avoid the drugs which may increase the intracranial pressure, because the patient with head injury already have increased intracranial pressure. So minimize multiple attempts during intubation. Give the drugs like beta blockers, which may mask the sympathetic tone, and also choose the drugs which may not increase intracranial pressure. So ketamine is not much good for this case, though it's still debatable. When you have you're in a situation whereby you don't have other option, but you have only ketamine, and the other hand is that if you cannot intubate the patient, will die, I better use the ketamine to intubate the patient, and then I will control the intracranial pressure by other means. So, and again, you have to rule out the fracture of the neck, cervical fracture, because for head injury, we have to immobilize the neck until you perform a chest the X-ray to rule out any fracture.
Thank you so much, Dr. Saria, for that explanation. I hope it is clear. I don't know if there's anyone who would have another question. Kama kuna mtu ana swali lingine. Okay, Dr. Saria, I have another question. What about the case in which you have trauma to the neck structures, like let's say you have a direct trauma to the trachea or the larynx? What are the things to consider now in case of intubation of this patient?
Okay, so when you have the trauma, let's say airway trauma, and when we say airway trauma, the airway start from the mouth or from the nasal strip up to the lungs. That's the airway. So when you have airway trauma, especially the upper airway trauma, whereby you have the larynx, the trachea, and the nose and mouth, you may face difficulty during intubation. But what I can say is you have to make sure that you prepare yourself, because when you have, let's say, anterior of the neck injury, so the anatomy will be distorted. So even with your conventional laryngoscopy, you may feel difficulty in intubating this patient. So when you have this kind of situation, try to include all the all the other stakeholders, the other teams, especially the ENT surgeons, because also the ENT surgeons are a little bit experienced when it comes to airway, especially the anatomy of the larynx and the trachea. So try to make sure that if you have the leisure of getting the ENT, try to involve them, the maxillofacial specialists, those who specialize in the head and neck surgeries. Try to involve them, because they may have also some input when it comes to airway management. But the most important things when it comes to airway injuries, is just to prepare. Make sure that if you have the fiber optic, make sure that you use it. If you have the video laryngoscope, make sure that it is available. The suction, the different blades, especially for this kind of situation, you may use large blades. So make sure that you prepare the blades as accordingly, and the tubes and the equipment and the drugs and the surgeons, they should be available, so that in case of emergency, they can try to do tracheostomy, emergency tracheostomy or cricothyrotomy. So it's all about preparation care.
Thank you, Doctor, so much for the explanation. Do we have any other questions from the spoke? Any comment regarding this case? maybe to begin with, I'll just choose one participant, Dr. Hakim. Have you had any cases of difficult intubation in your facility that you remember that you participate perhaps in the management, Dr. Hakim? Perhaps you can share with us how it went, what were the difficulties?
Asante, nimeshakumbana na hizo changamoto. Kwa kukumbuka nimewahi kupata hizo, lakini alikuwa mjamzito na ikawa ni difficult kwa sababu alikuwa ni severe preeclampsia. Kwa hiyo ilishindikana kabisa intubation kwa sababu alikuwa ameswell the tongue, the neck, the whole body was swollen. Kwa hiyo ikashindikana kuintubate. Kwa hiyo sisi tulitumia local anesthesia. Tulinfiltrate lidocaine kwenye abdomen, then tukaendelea. Ilikuwa difficult. Lakini pengine sijui kama swali litakaa vizuri, nilitaka nimuulize Dr. Saria. Hivi karibuni tulikuwa na mgonjwa wa head injury alikuwa amepata ajali. Yule mgonjwa alikuwa stiff, meno hayafunguki, alikuwa na spasm, alikuwa rigid body baada ya kupata hiyo ajali. Kwa hiyo tulikuwa na shida hata ya kusaki, ya kufanya nini, yupo amekuwa stiff meno na kila kitu. Sijui hapo kama changamoto za hivyo, kupata mgonjwa wa hivyo, how can we go about angalau kufungua mdomo kuweza kuingia humo ndani. Sijui kama swali ni sehemu yake au hapana. Asante Dr. Kevin.
Okay, asante sana Dr. Hakim. Nadhani swali ni nzuri. Swali lako la pili ni kama vile tulilijadili kidogo mwanzoni hapa. Dr. Saria, karibu kama unaweza kurespond. Dr. Saria, uko muted, akisha umeunmute.
Teknolojia Kevin. Okay, namshukuru daktari kwa swali lake. Nitaanza na swali la pili la kwa mgonjwa ambaye ana head injury alafu ana spasm za kwenye jaw na unahisi ana secretions, wanataka kufanya suction, sasa watafanyaje? Tukumbuke pia kwa wagonjwa ambao tayari wana head injury, hatushauri sana kuwasedate kwa sababu the only way ya kumrelax mgonjwa kama huyo ni either by using a muscle relaxant and sedation. But when you use muscle relaxant and sedation, lazima uwe na mtu ambaye anaweza kumanage airway. Because when you sedate the patient who is having already head injury, ataanza kupumua kwa shida, ata-accumulate carbon dioxide, utaworsen ile intracranial pressure. Kwa hiyo hatushauri sana kuwasedate wagonjwa ambao wana head injury. But when now the patient is having spasm and the patient is having secretion, the maneuvers za kwanza ni zile kwamba tujaribu ku open the airway kwa ku tilt the head, then tufanye jaw thrust na chin lift. Hizo manuva na uhakika zinaweza zisipunguze spasm, lakini zinaweza zikasaidia open the mouth. Na once tumefanikiwa ku open the mouth, let us put the oropharyngeal airway, kwa sababu ile oropharyngeal airway itatusaidia kwanza ku open the airway, alafu ndio itatusaidia kufanya suction, kupitisha suction catheter through the oropharyngeal airway. Kwa hiyo hizo ndo manuva ambazo ningeshauri, lakini kama hizo sasa zikifail and the Glasgow Coma scale, let's say is below 8, definitely mgonjwa atahitaji intubation. So kama kunahitaji suctioning, then they can go straight to induce the patient, paralyze the patient, intubate the patient so that they can control the airway na kuendelea kufanya suction. So la kwanza nilimiss kidogo, lakini nafikiri kwa nazungumzia issue ya walipata difficulty intubation, wakaishia kufanya under local anesthesia. Kwenye medicine hatuna yes or no, lakini kikubwa ni kumsaidia mgonjwa. So na inategemea sasa na aina gani ya procedure, na pia tuhakikishe kwamba whatever the technique ambayo tunatumia, at least tuhakikishe mgonjwa yuko comfortable, na wagonjwa watakuwa only comfortable when we control the pain. So if the patient is stable, the procedure allowed to be continued under local anesthesia, nafikiri they can proceed with the local, and then they make sure that the patient is comfortable. Because when the patient is comfortable, even the surgeons will be comfortable. Thank you.
Okay, asante sana daktari. Dr. Hakim, sijui una swali la ziada au umeridhika na majibu ya daktari hao?
Asante, nashukuru nimeridhika.
Sawa. St. Joseph Kagondo. Najua hii kesi imetokea St. Joseph, lakini labda kuna kesi nyingine ambayo mme-encounter ya difficult intubation ambayo mnaweza mkashare na sisi tukajifunza kitu. Okay. Mwingine yeyote mwenye swali au comment? Dr. Karima, naona umejoin session. Do you have any contribution to our session today?
Yeah, I'm sorry, nimechelewa. I came in late, so but from what I've heard, I think it was well covered and well discussed. The important thing I would like to emphasize is the preparation, as Saria said, preparation. That's the most important thing. The other thing is working together. So when you're in a crisis and you sometimes are unable to make decisions, so make sure you involve the other. Might be useful at that time. Kama hivyo ENT surgeon, as you ask for anterior, if there's a trauma to the anterior part of the neck, and you know most probably we will need the ENT people to help you. Kwa hiyo unawaita mapema, and yeah, so teamwork and asking for help and preparation, and also making sure that you don't behave like you're a hero. You can do anything. This is where your knowledge ends. Jaribu attempt vitu ambavyo beyond your knowledge or beyond your experience. Ask for other people to do it. There is no heroes in medicine, especially when it comes to the airway. Thank you.
Okay, asante sana daktari for your contribution. I think it's useful. The emphasis of teamwork, I think it has been further emphasized by Dr. Karima. So teamwork is very important, especially in managing any cases relating to difficulty in the airways. No heroism in medicine, always act as a team. I think that's one of the take-home message for today's session. Sijui kama kuna swali lingine, comments as we are going. Tumebakiza dakika 5 tumalize kipindi. Tarime Hospital, do you have any comment, question? Nyamiaga and Nyerere, our participants.
Okay, thanks for good presentation. Let me congratulate to Dr. Saria for good presentation. Is more explanation. But the one things which I can add on, if you have no other induction for propofol or thiopento, maybe you have a ketamine. You can minimize a dose of ketamine for those who have head injury to increase that intracranial pressure. And the one things which I can add on how to mobilize. If you think that this patient have a difficult airway or have difficult for intubation, make sure that you mobilize together, and make sure that have experts for anesthetists or anesthesiologists who have experienced. So you come together and you do how to improve that patient so that to improve the function of studio capacity. Thank you for good presentation.
Thank you so much. Give us your name. Remind us your name, please, the participant.
Yeah, my name is Mpogwiki Rukomo, anesthetics from Nyamiaga Hospital.
Okay, thank you so much, Rukomo, for the contribution. Dr. Karima, I saw that you were commenting. Do you have anything else to add?
No, sorry, my mic was on, but my child is talking here.
Okay.
It wasn't really me.
All right. Okay, Dr. Saria, any last words, take home message for the session?
Okay, asante Kevin, nitaongea kwa Kiswahili kwamba Kwanza niwapongeze hospitali ya St. Kagondo kwa kuweza kumanage kesi vizuri, wali anticipate difficult airway, wakajiandaa. Kwa kweli hao ni watu ambao wanafanya kazi katika mazingira magumu, lakini hawachoki, hawakati tamaa, wanaendelea kutoa anesthesia. Kwa hiyo tuendelee kuwapongeza na niwaendelee kuwashauri kwamba tusikate tamaa. Kwa limitation hizo ambazo tunazo, tuendelee kuboresha anesthesia yetu. Kwa vile vichache ambavyo tunavyo tuvitumie vizuri, mwisho wa siku wagonjwa wetu wataendelea kuwa salama. Kingine kama alivyosema Dr. Karima ni teamwork. Kwa hiyo tusiache kufanya kazi kama team kwa wote, the surgeons, the anesthetists, the nurses, kwa sababu kila mmoja ana mchango wake katika kumanage mgonjwa. Kingine tusisahau hizi tunaita CME. Tukishaenda makazini, tumesoma anesthesia, tumemaliza, tumepewa vyeti, tusipokuwa tunafanya continual medical education, tutasahau hata vile vidogo au vile vichache ambavyo tulikuwa navyo. Kwa hiyo tusiache kufanya CME, tusiache kufanya presentation, tusiache kukutana kila siku kudiscuss challenge za kwenye anesthesia tulizokutana nazo kwa siku hiyo, wapi tuboreshe. At the end of the day, haya vitu vidogo vidogo havitatushinda. Otherwise, nashukuru kwa wote ambao wameshiriki na natumaini session ilienda vizuri. Asante.
Okay, asante sana Dr. Saria. Kwa hiyo tumemaliza session kwa leo. Nashukuru also walio join. Wiki ijayo tutakuwa na surgical skills clinical session ambayo itakuwa led na Japaigo. Kwa hiyo nawakaribisha pia, nadhani itakuwa a very interesting session. Tunashukuru wote ambao mmejoin. Nashukuru Ali na Dr. Hakim kutoka Biaramlo. Thank you so much. Na wote mlio join. Niwatakie jioni njema, tutaonana wiki ijayo.
Asante, bye.
Okay, asante sana daktari. Okay.